Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Marc Swinkowski from the Journal of Bone and Joint Surgery.
Well, good morning, Mo. I understand that you're just so busy running around fulfilling your duties as a consultant as well as running a surgical department that you haven't had time to have any coffee this morning.
No, I have not. I have not. But I'm hoping you've had two, at least one for yourself and one for me.
I have had a cup and a half, and I've got my Ortho Joe with me. But before we do our very frequent what's caught your eye of interest in your publication session, I just wanted to point out that I'm still, in essence, pondering the conclusions of our Ortho Joe session on physician attire in patient care, as well as in scientific presentations. And I haven't decided which side I'm going to come down on the argument yet, but I just wanted to point out to you and those that are watching that I have my JBJS tie, but I've gone full retro with the three-piece suit today. Just to show you how bad it could be with geezers like myself who are stuck on this perhaps insignificant issue of professionalism of physician attire. So there it is, the three-piece suit. You probably have never seen one. You're so young.
You know what? Oh, no. I know it. And it's very distinguished. It's very distinguished. I mean, I think the only thing that could make you more distinguished is a cape and a monocle. And if you have the cape and a monocle.
No cape, no monocle. And I'm not sure I could grow a good enough beard to pull that off. But it's just, no, but I'll consider it. I'll consider it. But I'm still pondering that issue of Ortho Joe, and
it's
hope others found it of interest as well. So what's been on your mind recently from Ortho evidence perspective, or you were going to do, I guess, the second part of the OTA?
You know right? You know what? I mean, so we've got a couple of options here, and I actually wouldn't be, at taking sort of a co-moderator license. I'd love to hear more about what you were going to talk about. But mine was going to be highlights from, again, some trials presented at the recent trauma meeting, the Orthopedic Trauma Association, specifically focusing on, the important but question that gets asked a lot, and it's been recycled, has been, what do we do with the humeral shaft fracture? Operate or not? And if we operate, what do we do? So there was about 3 or 4 studies that had informed that. Marc, I'm happy to, I've got a few slides.
Keep going.
Yeah,
keep going.
Okay.
I've got a long-standing interest in this. Many years ago in the 90s, we did an RCT at Harborview Medical Center when I was chief there on nails versus plates.
Yeah. So, okay. Yeah, you're absolutely right. So let me just walk you through. I've got slides up here. And for those who are going to be listening via a podcast, I'll make sure that I'm clear about what they present. But again, we focus now in our second edition of installment of the Insight and Ortho Evidence, some highlights. And I've taken some original work, and we decide sometimes that there's work that's important, that's non-RCT, that's still important enough to present. But there was a cohort observational study of 290 patients presented from the Netherlands that fundamentally found the following: that when they looked at a bunch of patients followed forward, and the acronym is called the HUMMER study, HUMMER, that primary osteosynthesis of the humeral shaft fractures in adults was both as safe and superior to non-operative treatment. It should therefore be the treatment of choice. Ultimately, we saw that the symposium really promoting operative treatment of humeral shaft fractures. In fact, they said it's associated with a more than 2-fold reduced risk of non-union, better and earlier functional recovery, and better range of motion of the shoulder and elbow compared to non-operative. So certainly, you started seeing this push. Now, this was an observational study, so we said, okay, well, fair enough. What else is out there? And the same symposium, Marc, the Calgary group from Canada, part of a multi-center study, also did an analysis, a randomized trial of 168 patients, where basically they looked at the same thing: improved shoulder and elbow range of motion, and earlier return to work occurs following open reduction internal fixation of humeral diaphyseal fractures. So they really, again, in a small trial, but still an important one, promote that. Cost effectiveness was also evaluated at the same meeting. And this is, again, work coming out of the UK, Edinburgh. where they basically are making the argument, a bold one, that if we were to look at all humeral shaft fractures and fix all of them without really just anyone that that comes in gets fixed, it still may appear to be cost effective at 5 years post-injury, considering all of the potential issues with reoperations in the non-operative group. They also say if we can even get better at deciding which patients are more likely to have a risk of non-union, so that patient at risk, that cost effectiveness gets even greater. Keep going. There's another study that presented, a meta-analysis of 292 patients that basically says what I think has been the real promotional factor. Surgery may confer an earlier functional advantage to adults with humeral shaft fractures, but this is it's an early advantage. So at 1 year you're not seeing that functional gain, but the lower risk of non-union reintervention, there is a potential higher risk of transient radial nerve palsy. So that becomes the trade-off. And this again was more work presented by Tim White and the group out of the UK. Going back to work that we had done back in 2006, and I know this was included a trial that your group had done around that time as well. At the end of the day, when we looked at compression plating, the risk reduction with plating versus nailing was pretty high, right? So one reoperation could be presented for every 10 patients who are treated with plates compared to an intramedullary nail. So I'll stop there. There's a lot of stuff that I just mentioned, but the principle, Mark, from this whole meeting was that the issue of non-operative treatment came under some considerable scrutiny, and that's an interesting point. And again, plates still remain the gold standard, at least based on the evidence that was presented at this year's OTA.
Yeah, I think your concluding citation there is a really important one for the audience. Is there is a substantial risk of transient radial nerve palsy, and when we consider best management for an individual patient, we should be discussing this regardless of the surgical approach. Of course, it's a little more common posteriorly with that approach than it is anterolateral, but it is a real thing. And so I'm going to ask you, somebody who's invested the last 2 decades at least of your career in large trials, is it time for a large international multi-center trial to finally settle this question?
I think you're right. I mean, if you look at what's been done, I mean, when you see so many studies, albeit there's a lot of work coming out of the UK, if you saw the number of patients, studies are coming up, meta-analysis, cost effectiveness, all from the same group, basically. It does suggest that there's probably interest in doing that, and it's probably going to be happening. And you're probably right for the most part that we're going to likely need to see something larger. It's a very common fracture, so I don't know. There's no reason why we couldn't collaborate and do this. And I suspect, as we're speaking, there are groups right now doing exactly that.
Yeah, I agree. It's time, and it's probably, looking at those citations which you put up, it's probably going to be somewhere between 600 and 1,000 in each arm. And then the question is, do we do surgical versus non-surgical, or do we focus on plate versus nail?
So this is where you start getting into efficiency, right? And you can almost think about, that's a psychology of, you take all patients come in, they're randomized to operative, non-operative. Of the operative, they're randomized again to approach. You could think of that as one of the options. Now, that's going to require a considerable number of patients and, a considerable operation to get that going in terms of, the methodology and the funding. But that would be an efficient design or something similar.
Sure.
Where you're using, endpoints. I know we're starting to talk. We talked a lot about existing databases and administrative databases and collecting outcomes data on reoperations. Although I'm not sure how often, transient radial nerve palsy would be recorded in a lot of databases. So some of those things, depending on the outcome, we may need to be doing much more traditional data collection techniques.
Yeah, I think so, because if the nerve palsy is transient and it doesn't require tendon transfers, it's probably not going to show up in most databases.
Correct. Yeah.
So particularly with the way we generally manage those with expectancy and maybe a bracing period, but we certainly don't do much other than reassure the patient.
Right.
Well, that's very interesting. And thankfully, our orthopedic trauma community internationally has gotten so used to doing these collaborative trials. I think we can do it because we've done it with so many other topics, and
absolutely,
and we're fairly successful at it. I dare say more so than some of the other subspecialty communities, but they're all improving. Every single one of them. You can go right down the list: shoulder, shoulder, elbow, sports, on and on and on. We're really improving as an orthopedic community.
And you know what we're doing a lot of too, and I think you're going to speak to this, is we started moving into big data sets and even getting into the predictive modeling in terms of what's encoded in us from the day that we're born, right? The idea of, which I think you're going to speak about next, which is this genome-wide types of association studies. I mean, this is the kind of stuff that is, as we start looking into the future, it looks like it's the new domain of where we're going. However, there are real risks, and so I'm sure we'll have some chat about that too.
Yeah, well, thanks for the introduction, Mo. So I am going to be speaking about this article for those of you looking on video. It's from the November 2nd issue of the Journal of Bone and Joint Surgery, entitled "Genome-wide Association Study of Adhesive Capsulitis Suggests Significant Genetic Risk Factors," from the Hospital for Special Surgery group. Scott Rodeo is the senior author, and it's a very, very interesting study. We know that adhesive capsulitis of the shoulder has been associated with hypothyroid disease as well as diabetes, and it tends to be more common in the female sex. And what this group of investigators did was they used the UK Biobank, which has been used in a number of musculoskeletal condition studies, looked at 500,000 patients with their genetic data and their ICD-10 codes for disease. And they compared 2,142 patients with ICD-10 code for adhesive capsulitis to those without the same number. And they looked at these genome-wide associations, controlling for the two known risk factors of adhesive capsulitis, hypothyroidism, and diabetes. That did logistic regression. And what they came up with was 3 loci of significance, even after controlling for hypothyroid and diabetes. It's a very, very interesting study, which concludes the total genetic risk associated with adhesive capsulitis was significant and similar to the risk associated with hypothyroidism and diabetes. And they identified these 3 genes, which implies the Wnt pathway. So very, very interesting study. And we've seen others with osteoarthritis looking at the risk factors using the same UK Biobank. And it seems to me that, when we consider large multi-center trials on whatever condition, whether it's a injury condition or whether it's a disease condition, that individual genetics has got to play a role in not only the disease severity, but response to treatment, et cetera. So my question for you is, when are we going to be at the level where we are looking at the genetics of the patient as we involve them in multi-center interventional trials? How far off is that?
I don't think it's very far off at all. And I must say, it's a very timely topic. So in the last month or two, there's been a lot of cardiovascular groups at our institution looking at, genome specific or genome wide association studies. So I must say, I was a little ignorant to really the methodology. It is a complex methodology with a very clear pathway. And if you look at a host of different groups, there's lots of great publications. One in Nature, for example, that talks about, sort of the pearls and the potential perils. But just for the audience, if you'll indulge me, Marc, I have a couple little excerpts I'd like to share with you about genome-wide. First of all, for those of you who are listening in, somewhat like me, maybe a couple of months ago, was what exactly is a genome-wide association study? What they're doing, as I understand, is they're testing hundreds of genetic variants across many genomes to find these statistically associated with some sort of specific trait. And we've seen great things happen. Obesity has had, this type of study linked to understanding, what is the genetic variant associated with it. Crohn's disease had similar. So there's huge value to this. But here's the challenge I think we face, and it's the issue with the Bonferroni correction. Let me read this one passage for you. Okay. Testing millions of associations between individual genetic variants and a phenotype of interest requires a very stringent multiple testing threshold to avoid false positive. And that's that whole issue of the fishing experiment, data dredging, standard with any large databases that we look. So there's been projects, one called the International HapMap Project, that's done this. And here's what they found. They said that there's at least 1 million or close to that independent common genetic variants across the human genome on average. What does that mean? You have to correct your p-value roughly by that number of different potential common associations. So guess what the new p-value for a statistically significant finding would be in a standard genome-wide association study? P less than 5 to the 10 to the negative 8. So go back 8 zeros. That is getting to the point where we're starting to get rid of that variability. So as with anything, the challenge we're always going to face is, one, do we have a big enough sample size to do this, which I think you do? And number two is, are we appropriately not coming up with what we're calling, false positives? And so another thing we have to be doing more of, Mark, is we have to making sure, as I suspect happened in this study, is that there's an independent validation cohort with the same stringent p-value. So if you see it twice, it starts looking more like something. But they talk about, the idea of doing these independent tests, just like we do in anything else where you're validating it. So for me, I think it's hugely important. It's a huge advance. But with that huge advance, we have to have a lot of caution how we interpret all these positive findings.
Yeah, it's really a variation of the discussion we've been having on machine learning. Basically, it's a statistical issue, and we have to be really, really sure we're controlling well for all the potential influences on the result.
Right.
Well, I think we'll be talking about this for a few years. That would be my guess. So
easily.
But it's always a pleasure for me to give you the opportunity to prove to the audience that you really are more than just a trauma surgeon, that you're interested in genetics and the whole issue of you quoted cardiology. So all of human medicine, you're really the Renaissance man of medicine. Mo.
And Mark, I do that without a tie in just a sweater, just a warm sweater, just reminding everyone it's winter. It's winter in Canada. It's coming.
The debate goes on, doesn't it? Well, that's good. Well, I'm going to enjoy the rest of my coffee and hope you can find some, and have a good rest of your day.
You too. Take care. Have a great day.
Okay. Cheers. Bye.
Cheers.